Hello, hello. It's good to be back. Welcome to another Polestar Pilates Hour. It's been a while, and it's exciting to be with you again. And we're going to be talking about human physiology. So, a while ago, I did one on muscles and nerves. And today, I'm excited to share one on bones and joints. We've got a lot of information. And my goal today is to really emphasize how important it is for us to understand the physiology of bones and joints as it pertains to movement. And that's really the whole essence of this program, isn't it? Is that we understand movement in a way that it is very clear to us, that we can use our tools as Pilates teachers, physical therapists, gyrotonic teachers, yoga instructors, Feldenkrais practitioners, all of the above to bring a heightened sense of awareness and movement to our community. So that's something that's super important. Let's go ahead and get started. So I've broken this down into 4 areas or 5 areas as we talk about bones and bone tissue. One is function, one is its classification, the other is structure, and then development and homeostasis. So we understand exactly what is going on in the bones, and this will also help us understand some of the pathology that we look at. So when we look at support, this is an obvious one, but sometimes not so obvious, that we are a very unique animal. We are bipedal mammals. We have a bicurve spine, and that in itself makes us very unique. Even the primate is a bipedal animal at times, but they do not have a bicurve spine. And so our bones are specifically evolved and developed to maintain us in an upright position and support us. And not only our muscles, because if we didn't have bones, we'd just be like a jellyfish, but also our organs attached to the bones and the skeleton. So the way that it sustains our heart and our lungs, our gut, how it protects our brain and our eyes, the ability for us to have a digestive system from the opening in the mouth to the opening in the pelvis. So a very powerful tool for us to think of is just support. So a healthy skeleton provides healthy support for the body, for the tissues, for the muscles, the nerves, etc. The pelvis and spine and the rib cage support all the organs, as I mentioned, and allows us to be these beautiful bipedal animals. Protection-wise, it also makes a lot of sense because the bone is tough and it's hard and it's going to protect us. First and foremost, probably the best protection we have is our skull. So if you've ever fallen down and hit your head pretty hard, most of the time we're pretty grateful that we have a hard skull to protect our brains, right? Sometimes they get hit so hard that it actually does damage in spite of the skull, but that's its purpose. It really protects us. And likewise, the vertebral column protects our spinal cord. So the central nervous system is protected by the skeleton. The other thing it does is the rib cage and the thoracic spine and the sternum, they all protect our vital organs. So you can think of things like our lungs and heart are protected as well by a cage that's flexible and supple and allows us to move through space. The next one is movement. And of course, we're going to dive deep into this one, but movement is essential for everything we do, the skeleton. We cannot accelerate or decelerate or reach, jump, stand, absorb without the skeleton. The skeleton is our movement. And what happens is the neuromuscular system lays on top of it and moves this really interesting set of bones in different directions that provide us function. So we can walk, we can jump, we can swim, we can climb, we can run, all of the different things that our bodies do. Pretty cool. It is the framework in which our neuromuscular system is capable of executing movement. And we just have to always go back and think, and we talk about joints in a little bit. How does the skeleton accelerate, decelerate movement? How do we move these long bones? I brought a number of bones with me today, of course, but just thinking of how does something like a femur, based on how the muscle attached to it, give us acceleration and power and speed when we are walking or running. So we're going to talk a little bit about that, but really thinking of the skeleton and the bones are essential for us to move. The fourth one on here is storage. And storage is one that sometimes people don't really think of, but we have so much that is stored inside our bones, particularly minerals. So we store calcium, phosphorus, magnesium, sulfur, copper, all of these essential minerals and ions that are necessary for the function of our brain, our heart, our digestion. Every aspect of our health and well-being depend on this. One of the most important ones being calcium. So we know that our bones are rich in calcium and that this is where our calcium is stored. And we'll talk about that a little bit more. But this is where our calcium is stored. And then when we need calcium in our blood, we actually break the calcium down or the other minerals down in the bone to have it accessed in the blood. And when we have an excess amount of those ions, they go back into the bone storage. So our bones are always remaking themselves. And that's why if you had a fracture, you could see how the bones will just mend that fracture and make it strong again. When we look at diseases of this, we're looking at things like osteoporosis and osteomalacia and other bone diseases. The last one, and probably the most important one for us that we don't think about at all, is the idea of blood cell formation. So the majority of our blood cells, white blood cells, red blood cells, our immune system, our beta cells or B cells, those are all coming from the bone. And the bone marrow is where a lot of these cells are produced. And so we have new red blood cells every single number of days that are being reproduced as the old ones die. And that production of those blood cells is happening inside of our bones. You've obviously heard times when somebody says about a bone marrow transplant, right? So the bone marrow transplant, what they're doing is they're going in looking for blood plasma. They're looking for these B cells. They're looking for a number of the white blood cells, the red blood cells that they could use to be able to help people with immune deficiency or to fight cancer, et cetera, et cetera. So they're going into that long bone. And typically the way they do that is they go into the top of the femur and they drill down into the long needle into the shaft and they draw the blood cells out of the shaft for that transplant. So bones, 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 especially long bones. Let's take a look at the nature of bones. So in the classification of bones, we have typical bone names or classifications that basically describe them. For example, the long bones typically are extremities. So they're going to be the humerus, they're going to be the forearm, the ulna, and the radius. They're going to be the femur, they're going to be the tibia and fibula. Those are our long bones. But even so, sometimes confusing, our fingers are long bones as well, right? They're phalanges. So long bone means more about the shape of the bone. So I'll bring another bone up here and look and just sort of think the epiphysis on both ends of the bone, and then we have the shaft, right, or the long bone. So what makes it long is that there's a long shaft on it. Just like my finger has a shaft on it, they just look a lot smaller, but they have the same exact components and structure of it. Short bones, on the other hand, would be things like in our wrists or in our ankles. So we have 8 carpal bones, 8 tarsal bones. Those bones tend to be unique shapes. They're hard on the outside, spongy on the inside, and they articulate and slide with the bone next to them. We often refer to them as small bones or short bones. And then we have irregular bones. So the vertebra in particular, the vertebrae can be very irregular if you were thinking of how unique is the shape of a vertebra. So if I look at the vertebra here, this is a very unique shape of how the bone is designed. It's not a long bone. It's not a short bone. It's a unique bone. And so things like the vertebra, irregular shape, sort of cool. We need them. They protect our spinal cord. They facilitate movement, and they provide protection to the body. And they make up our axial skeleton, which allows us to stand up straight. And that's why we have the bicurve, which I'll talk about a little bit more. Inside of this structure of long bones, short bones, irregular bones, flat bones, we have 2 types of osseous types. So one of them is a trabecular bone, and that is a spongy inside. So when we look at our vertebra, inside the body of the vertebra is trabecular bone. It's spongy bone. And this you would often hear of people saying if they had osteoporosis in this vertebra, that the bone, the spongy part of the bone or the trabecular bone becomes very fragile and very weak. So if there's too much pressure on it, it could collapse the vertebrae around that trabecular bone. The other is cortical bone, or it is compact bone. And so that's what we think of more when we're thinking of the long bones or the leg bones, is that the bone is very hard on the outside. That's that calcification, compact cortical bone that surrounds the inside of the bone, which is softer and is more trabecular. That's where all of the blood cell formation takes place, is in these long bones. So it's often referred to interchangeably of talking about spongy or trabecular and compact or cortical bone. So for example, our skull is compact bone and it is flat bone, okay? So we'll continue to use those terminologies as we work through this. When we look at the structure of bone, gets a little interesting. So we talked about the diaphysis, which is the long shaft of the bone. So if we look at this diagram, we can see that. I'm going to bring up a little annotation device for us so we can see that. And here we can see the long bone. This is considered the diaphysis, and inside the long bone is called the yellow bone marrow cavity. And it's in that cavity that these blood cells and white blood cells are made and stored, and it's soft. And so if you've ever been to a good restaurant, like a good French restaurant, and they offer you bone marrow, what they're doing is a cow, they split the bone in half, and you scoop out the inside of that bone, and that's the bone marrow. And it's actually considered a delicacy, right? So when we look at the next picture over, we can see that yellow inside of there, the bone marrow that is used to reproduce. And there's even a close-up view of it here, the yellow marrow of the bone. The other part of the bone that we often talk about, especially with adolescents and young children that have injuries to their bone, is the epiphysis. So the epiphysis is the distal end of the long bone, and the epiphysis is a hard bone, and so is the diaphysis, but in between it in a growing child is the diaphysis, and the epiphyseal plate. And the epiphyseal plate is a cartilaginous material that will grow. So the bone grows as we get taller, as we age, as we go through puberty. It continues to grow until we reach puberty. And then once we've finished our growing spurt, those become hardened and calcified just like all the other bones. So you often might see a line, and that line is called the epiphyseal line inside of a bone. So just to reiterate, diaphysis is the shaft, epiphysis is the ends of the bones, and the epiphyseal plate is where the growth plate was. So you'll hear people talk about, well, did they have a fracture through their growth plate if they were a child? Because that could stop or impair the growing of those bones that's needed for normal maturity. Another very important part of the bone makeup is the periosteum. And to me, the periosteum is something really incredible. It's sort of like a saran wrap that surrounds the bone. It's this connective tissue. We certainly know it's fascia, right? So it's made of fascia, has the connective tissue in it, and it holds our bone together. And there's some new research looking at it that the fascia is one of the highest, it has one of the highest counts of Golgi organs in it. And that is part of our vertical orientation. So it makes sense that that is around the fascia of the body and also the fascia surrounding the bone, and that it gives us feedback. What's interesting to me is when we have a fracture or an injury, it is the periosteum that often gets and creates the signal, and the tension on that periosteum that allows to speed up the healing of that fractured cortical bone. So the periosteum is also what the tendons attach to when they're attaching to the bone. So they meld onto that bone. And I think it's important to realize, for example, something like shin splints. If you've ever heard of shin splints, I was famous for getting them when I pole vaulted in high school. And that pounding sensation, it has those calf muscles that are hooked on to that periosteum around the bone. And they literally pull the periosteum away from the bone and causes an inflammation between the cortical bone and the periosteum. And that can be very painful. And so that periosteum is very responsible for maintaining the integrity of the bone as well. So when we look at fractures, it helps keep things aligned and keep things together. And the irony of this is we don't really see the periosteum on the X-ray or even necessarily the MRI so clearly. So when you look at the bone actually has been fractured or open reduction, you can see the connective tissue around the bone. The endosteum is another connective tissue that's on the inside of the bone. So that we're going to be looking at more inside of here in the trabecular bone. If you look at my highlighter, and that highlighter is showing that where the little vascularization in the nerves are, that there is this connective tissue that lines it, and that is called the endosteum. The other thing that's really important about our joints is the articular cartilage. And articular cartilage is typically going to be at the end or the surface of the hard surface of the epiphysis. And this is where we have normal chondral articulating cartilage. And the cartilage is a hyaline cartilage. So this cartilage is made to absorb shock. It's made to be smooth and to glide on the surface of the other bone, which will make up our joints, which we'll talk about in a little bit. We talked a little bit about short, irregular, and flat bones, saying that they have a thin plate of periosteum as well that covers that compact bone. And they also have the endosteum that is covering the spongy bone within. So the connective tissue is everywhere. It's communicating with everything. My dear friend Carol Davis has taught this for years of understanding that bones are crystallized fascia, and that we're looking at this connective tissue of the entire body communicating, and that this is important for our skeleton as well as it is for our muscles. So now we look at the homeostasis of bones, and homeostasis means the balance. It's like, how do bones maintain their normal rigid structure and continue to provide the minerals that our body needs? And bone remodeling is something that happens to all of our bones all the time. So bone remodeling is typically hormone controlled, or it is load controlled. So we'll talk about both of those. The hormones that we talk about often have to do with the thyroid and the parathyroid that are managing some of the osteoblast and the osteoclastic activity of the bones themselves. So let's go through a little definition. An osteoblast is actually a bone cell that is going to lay down new bone. So it's going to make new bone. It's going to put new cortical bone down, new spongy bone down. It's reproducing that, right? Osteoclast is going to take it away. A clast is like a Pac-Man or something that's going to eat the bone or demineralize the bone to be able to free up the ions that are needed in the blood. So this is a very normal response. This is very important we understand, because sometimes people think that osteoclasts are bad and osteoblasts are good. That's not true. Both of them are essential in maintaining homeostasis. So let's go through a couple examples of this. The osteoclastic hormones, particularly the parathyroid hormone, is released when the ion calcium count is too low in the blood. So it has like a little meter, and it's a feedback mechanism, and it says, hey, there's not enough calcium ions in the blood that we need for our brain, we need for our muscles, we need for our digestion. We need this mineral everywhere. All of our nerves depend on calcium, to the ion, to be able to communicate. So if you don't have enough calcium, you can't communicate, your heart doesn't work, your muscles don't work, major problems, right? So when the body feels like the calcium levels are too low in the blood, it releases the parathyroid hormone. The parathyroid hormone will then cause an osteoclastic activity. So it's going to demineralize the bone, and it's going to free up calcium ions or other mineral ions into the bloodstream. This is called a negative feedback loop. When the blood is filled up now with appropriate amount of calcium, the sensory of that mineral now is telling the parathyroid it can turn off. There's enough calcium in the blood. If there's too much calcium in the blood, then the thyroid gland is going to release another hormone called calcitonin. And calcitonin, will cause the calcium ions to be turned into a salt, a calcium salt that will be redeposited onto the bones. So this process is happening all the time. There are diseases where there is an imbalance of this. So for example, if there's too much bone development, too much osteoblastic activity, we can have lumpy and bone spurs and all kinds of additional bone growth. I forget the name exactly of the disease, but I think of the show of Princess Bride and the big guy the big guy, Cro-Magnon, something like that. I'll have to look it up and I'll put it in the notes. But the bones grow too much, right? There's growth hormone and they just get too big. And when we're done growing, so we reach puberty, then the bones start to deform and get bulky and hard. On the other hand of the side of that would be something like osteoporosis. So if we have too much osteoclastic activity or not enough osteoblastic activity, the bone demineralization changes. We often call this a bone mineralization problem, right? So the bones are demineralized, the bones become weak. Certain bones become weaker than others because of their nature, and they can have fracture. So this is important, just thinking of the hormone balance of this right now. We're looking at the parathyroid hormone, and we're also looking at the calcitonin hormone. And these hormones are designed to help us maintain the balance. Now, there's another part to this that we can influence as therapists, Pilates teachers, exercise influencers, and that is load. So mechanical load tells the bones to release or to use more osteoblastic activity. So what happens is a bone that gets stressed, if I take this long bone again and I bent the bone to one side of the screen, right? The side of compression is going to send out a negative impulse. And that negative impulse is going to require more bone density if that continues. So the idea is if I'm going hiking or I have weight on my back or I'm doing things up and down stairs, that compression sends out a negative ion message requiring more calcium. And that message then releases the calcitonin from the thyroid and it facilitates osteoblastic activity. So our clients and patients who are dealing with bone density issues like osteoporosis, we want them doing a lot of upright activity, a lot of walking, a lot of climbing stairs and going downstairs to increase the load on the bones. And that load on the bones will strengthen their bones. Now, there also is pharmacological treatment, which they do a lot of different types of pharmacology where they bring in pharmacology that can increase the osteoblastic activity or pharmacology that will decrease the osteoclastic activity, taking the bone down. So you can imagine what is really influencing then is going to be the hormones in the thyroid gland or in the parathyroid gland. So it sort of comes together, and it's nice for us to know that our greatest influence in bone density is going to be able to increase the load on the bone. And particularly the load in the vertical axis is where we want to do that the most. This is why we have precautions. For example, somebody who already has osteoporosis, they have a precaution of compressed forward bending. Why? Because that trabecular bone that we talked about here, it already is weak. So if I push these two end plates together, I can break it, right? And that's what we want to prevent. We want to prevent that collapse of the vertebral bodies, particularly in the lower thoracic and the upper lumbar. Let's continue on. So this just concludes our discussion for now on bones, but the idea here is that we're looking at what is bone pathology, right? So I'm looking at a couple of them here. So we see osteoporosis, the one that's the most common. We look over here on the right, we can see the osteoporotic changes. The top part we're looking at is trabecular bone. So on the left of the screen, this is a healthy trabecular bone. And remember, inside of that trabeculi is going to be blood vessels, nerve vessels, white blood cells being formed. We're going to find a lot of the beginner cells and beta cells of our body that are being formed in those bones. If we look over here, we see that the bone has been demineralized. So there's been a lot of osteoclastic activity, not a lot of osteoblastic activity. And what that's going to lead to is weaker bones. So common places for fractures that are associated with this could be in the neck of the humerus. It could definitely be in the vertebral bodies, as we talked about. It could also be in other long bones that could weaken in the wrist. We often hear about fractures in the wrist. I do have a comment coming in, which is perfect timing. So if you have any questions about bones in particular before we move into the skeleton, Sarah Edwards. Sarah, how are you doing? She said, hi, Brent, can thyroid conditions like hyperthyroidism and hypothyroidism influence bone structure? And the answer to that is absolutely yes. So again, thinking of the thyroid hormones, and again, not getting caught up in necessarily the thyroid hormone, but the growth hormones do have influence on bone density. So if you had a cancer or you had a tumor or you had a dysfunctional hypothyroidism, it could lead to a decreased restructuring or remodeling of the bones. So absolutely. So let's move into the skeleton, because I want to make sure we get and have plenty of time to go into the joints. And that's really where we make our money, is making sure joints are moving. But we have to also understand the skeleton. So we start off with what's called the axial skeleton. So we talk about axial elongation in Polestar a lot. We're talking about the lengthening, right, of the axial skeleton. So that consists of the sacrum, the lumbar vertebra, the thoracic vertebra, the cervical vertebra, and the head, as well as the thorax, which would include ribs and sternum. So we think of the idea of this axial organization of our skeleton. This protects our viscera, it protects our spinal cord, as we mentioned, and it provides us with the uprightness and the ability to use our appendages, which is the next slide I want to show you. So when we look at the appendicular skeleton of the upper extremity, this includes the shoulder girdle. So the scapula sits on the rib cage, the clavicle sits on top of the rib cage. They connect to the humerus, the upper arm, and create the shoulder, or the shoulder girdle. And then the humerus articulates with the ulna and radius, it makes the elbow, and the ulna and radius with the carpal bones that make the wrist, and then the metacarpal bones of the palm of the hand and the fingers. All of those are long bones except for the carpal bones in the wrist and the irregular bones in the scapula. Then we go to the appendicular skeleton of the lower extremity. And again, a lot of this makes sense, but it's important for us to understand and use the right terminology as we continue to progress our studies into pathokinesiology over the next year, which I'll be excited to tell you about at the end of the lecture today. So pelvic girdle, the ilium, the ischium, and the pubis are fused bones. So we can see that here, right? The sacrum wedges down in between that. And there's something sort of cool about this. The width of the sacrum, if we look at the widest point of the sacrum where the dot is, and I draw a straight line down, it puts it right on top of the head of the femur. So the gravitational line, and then you look at the line of the femur coming in, that puts everything on that central axis coming over the second toe. So as bipedal animals, we barely have to shift our pelvis an inch to the side to be able to have a perfect symmetrical lineup of the spine over the hip joint, over the knee, over the ankle, over the second toe. It's a very unique feature that we have. Apes and monkeys don't have this same feature. Their pelvis is very wide, and they have to shift their body weight side to side to be able to locomote, where we can keep a very sagittal move in our locomotion because of that center of gravity being so close and the angle of the femur coming in. It's a very cool feature. Once we get to the knee, we have the tibia and the fibula underneath, and that articulates with the tarsus, or the ankle, and that with the metatarsus, which is going to be the sole of the foot, and then the toes, just like the hands, which are the phalanges. All right, now we get to move into the part I'm really excited about. I love all of that, but I love joints. And that's not the kind of joint that you smoke, the kind of joints that move us. Any questions up until now, please feel free to ask, and I would be feeling free to answer those. Are you thinking about those? All right. So here's a couple questions for you that you can maybe answer inside the chat if you want to. But when we talk about joints, most of us refer to movement happening in the synovial joint. In your own words, in like one sentence, how would you define a synovial joint or the moving joints of the body just to your client or to your patient? What would you tell them a joint is? So I see Karen Wilder. So when bones come together, a connection or connection between two bones, two or more bones intersecting. Good. This is really important because we often define things by the bones, and then we talk about a joint, like a knee joint or a hip joint. So we say the femur bone and the knee joint, but the knee joint is the femur bone and the tibia and the fibula and the patella. So it could be more than one bone that come together to create that joint. And the joints are where the movement happens, right? And that's what Bridget said. So thank you, Bridget, for that. One of my favorite images of a joint was shared with me by Shelley. I don't know where Shelley got it, but she's the one that shared it with me. And that was the idea of like opening a jar. So we turn the lid and the bottle or the jar in opposite directions is how movement takes place in joints. So they have to go in different directions for the two long bones or the small bones to be able to have displacement. And that's what we're really looking for, is displacement of these or between bones. Now, there are other types of joints that we have. We have joints that are fibrous, like the joints in our skull, right? I think I have a skull here. Well, I'm missing half of it. But I was looking and thinking of like there are fibrous joints that line the different lobes or the bones of the brain. So we could think of things like the parietal lobe, the frontal lobe, the temporal lobe, and they have these fibrous sutures that when we're children and young and growing, they have some movement in them. So if you've ever held a child's head, you can feel some movement. And also if you study craniosacral therapy, you also will be able to feel a little bit of the movement and displacement that happens between these fibrous joints in the skull, right? There also is a syndesmosis. So one that's very popular, we talk a lot about, is between the tibia and the fibula in the ankle. So this is a very important joint where it is pretty much fused. But if you damage that syndesmosis, you will lose ankle stability. It maintains the stability between the talocrural joint, so between the tibia and the fibula and the talus. So the crural is that syndesmosis, so that's important. And then the gomphosis actually is our teeth. You don't think of that very often, but our teeth do move inside of a socket, hopefully not too much, but that is called a gomphosis. So those are sort of fibrous joints. Another common joint that we don't talk about very much, but we should, especially in Pilates, is the cartilaginous joint or the symphysis. You've heard talk about the pubic symphysis joint. So the pubic symphysis is almost like a little rubbery disc in between the two pubic rami in the pelvis, and that there is movement there, right? It's not necessarily a synovial joint. It's not gliding, but there is some fulcruming and movement, especially in partum, that there is movement in the pubic symphysis. Then we go into our synovial joints, and this is what I want to talk a little bit more about. But the synovial joints, this is where movement takes place, all articulating joints. We look at a couple things that have to be there for it to be an articulating joint. So number one, articulating cartilage. So we talked about the cartilage at the end of the bone. It needs to have cartilage to interact with the other bone or the other bones, and is surrounded by the hyaline cartilage that allows them to articulate together. There is a joint cavity. That joint cavity is where that joint exists. So there's going to be some kind of cavity for it to come together. There are articular capsules. So the capsule has a fibrous outer layer, and it has the synovial inner layer. So you hear a lot of people talk about synovial fluid or synovial movement. Synovial is the lubricating of a joint. If it gets inflamed, and I just taught a course on rheumatology last week. I think some of you were there virtually, hopefully. And the synovium becomes a target for inflammation and for the immune system. It's called autoimmune disease. And the body attacks the synovial fluid and causes incredible deformation and destruction of the joint. And that's called rheumatoid arthritis. That's the part that gets attacked. Also, we see things like the reinforcing ligaments that surround joints, and they're necessary to be able to maintain the integrity of the organization of the joint. Now, how many of you, this is a rhetorical question, but how many of you have had a knee injury or an ankle injury, probably the most common is ankle sprains, that you displaced or sprained the ligaments on the side of your ankle by falling down, tripping, running, whatever, playing sports. Soccer often has a lot of these ankle injuries. Basketball has a lot of these injuries. And you actually deformed the ligaments. The deformation of those ligaments leads to a chronic instability structurally for those joints. So the ligaments become very important in maintaining alignment, dynamic alignment of that joint. It creates the proper amount of tension around that joint to allow it to do its proper articulation in the proper planes of movement that are particular to that joint. So for example, we could look at some joints that are very simple, like an elbow that is a hinge joint versus something that's like a ball and socket joint. We'll go into a little more detail that can move in all planes in all directions. We want to spend some time there. So factors that influence joint stability. This is something we've talked about in Polestar for a while, is Punjabi's model. So we have what we would continue to sort of focus on is this non-contractile structure that'd be like the ligament or the capsule. We have the contractile structures like the muscles and the tendons, and then we have the neuromuscular control coming from the central nervous system, right? And these all need to be in place to have a subconscious stability in a joint. Now, remember, stability does not mean rigidity. That is a common mistake that is often made in our professions, but stability means control of movement. And if a joint is meant to do plantar flexion and dorsiflexion, how do we prevent it from doing excessive translation or lateral translation? Well, it's going to be by the ligamentous control. When the ligaments are damaged, the only way we can control that now is going to be through neuromuscular. So it's just to understand this triangle that allows us to try to maintain that dynamic alignment subconsciously of these joints to allow the movement we need to locomote, to jump, to squat, any of the activities that we participate in. There's a comment here or a question. Rosana de Guzman, hello Rosana, says, can you comment and expand on how the scapulothoracic joint works? We're going to get there, and that's going to be a question I'm going to pose to everybody in a few minutes about the scapulothoracic joint. So thanks for bringing that up, and we will explain that. Movements are allowed by the synovial joints can be the following. This is important to understand. They can be non-axial, so they could just be slipping on each other like the wrist bones, the carpal bones. They could be uniaxial. Like I said, the elbow is a hinge joint, so that humeral ulnar joint only moves in one plane. It doesn't have much joint play besides that. And then you could have biaxial, which could be two planes of movement. So for example, the knee could have a little bit of rotation and a little bit of flexion, or a lot of flexion extension. And we could have multiaxial, which could be something like a ball and socket joint that can move in all planes of movement. So 3 types of movement that we typically look at beyond gliding. So gliding is the first one, and we have gliding movements would be like our vertebrae. So we talk about the vertebral dance, and we bring our arms up. If everybody does this with me, if we turn our arms this way, we are in the lumbar spine. And going up and down in the lumbar spine, that's going to be flexion extension. So it's just the facets gliding on each other. If we go into the thoracic spine and we glide, it's going to lead to a rotation or a flexion extension. And so those are good examples of gliding movement. We also see the gliding movement inside of the wrist and inside the ankles and the tarsal and the carpal bones rubbing up against each other, right? Angular movement is when we actually are looking at the bones moving away from each other or towards each other. This often would fall into the flexion and extension category, or abduction and adduction, and even circumduction falls into angular movement. So you could think of our knees definitely do that, our ankles do that, our toes do that. We have our elbows, our shoulders, our hips move in that flexion extension plane, and also move in the abduction adduction plane, and also provide circumduction. Now, we do have a special particular one, which is rotation. and rotating long bones around its axis. So that is going to be things like internal and external rotation. Sometimes you have to be careful that circumduction is not necessarily rotation, but we're thinking if I have my arm here, can I rotate it around the axis? So pronation and supination could fall into that as well. But if we did internal, external rotation in our hips or with our legs or with our arms, those would fall into rotation. The spine also has elements of rotation. Special movements, we could look at things like pronation and supination, inversion, eversion in the ankles, protraction, retraction. And now I want to ask a question. So this goes back to Rosanna's question. What type of a joint is the scapulothoracic joint? What type of joint is it? And you can answer that inside your chat. I'd love to wait and see what your answers are. So I see gliding joints on other people. I see question marks. All of them, not a true joint. Who said that? Sandra said that. Not technically a joint. Dorothy Jeffries. All right, we're getting some good answers in there. So the scapulothoracic joint actually is not a joint. We often classify it as it is, but there is, again, if we had rules to our joints, remember we said that you would have to have a capsule. So there's no capsule in that joint. There is no articulating cartilage. There is no synovial fluid. So what you have is the scapula and its fascia that surrounds it, that lays on top of the rib cage and the fascia that surrounds the rib cage. And then it's tethered by muscles in all different directions. So it has the levator scapulae coming up. It has the trapezius muscle coming up. It has the rhomboids pulling towards the spine. It has the serratus anterior pulling around the trunk. It has the latissimus coming down. So it has muscles that pull it in all directions. So what are some of those motions that we have of the scapula? So let's do it together. We can do an elevation and we can do a depression. We can do protraction and retraction. And we can do an upward rotation and a downward rotation. So when we think of movement here, what might be needed in addition for somebody that wants to play tennis and they want to be able to do an overhead strike or volleyball or throw a ball? What you're going to see is that the scapula itself does not go into extension and it does not go into vertical rotation. So it is dependent upon the movement of the thorax to achieve those motions. So somebody, for example, that does not have enough thoracic mobility to facilitate that overhead strike will either result in two things. One of them is they sublux their shoulder, and the other one is they move their low back too much. And so you'll see a lot of people that don't truly understand the joints of their body, how the scapula works in conjunction with the thoracic, will often have rotator cuff injuries and low back injuries when they're playing overhead sports or doing overhead activities on a repeated basis. Just a little side note there. Let's jump into types of synovial joints. So here I have a couple sort of mechanical demonstrations of them, and I'm going to point to each one of them. The plane joint down here on the very lowest part is looking at the talus, and it's looking at the glide or the plane joint that's flat, right? Then we could look at the next one, which is a hinge joint. So I'll come up to the top right corner here. This would be something like the elbow I mentioned, and it's just like the hinge of a door, and that hinge only moves in one plane. And typically we think of hinge joints as being in the sagittal plane with flexion and extension. The next one is a pivot. So the pivot could be, for example, in the neck is a pivot joint. So we have in the C1, C2, there is the bone that sticks up from C2 that the C1 pivots around. That's a pivot joint. We also have a pivot joint around the sternum. And so we also have pivot joints around the ribs. So those are examples of some pivot joints. We then can go to condyle joints, and this is what we might see in the knees, where the femur has two condyles, and those condyles can have movement in sort of a dome relationship. They move around the condyle, okay? And there's lots of condyles in our body. So we can look at condyles in the ribs, we can look at condyles in the lower extremities and upper extremities. And then we have another unique one that is called a saddle joint. So I'm just going to throw this out here for another interactive question. What is a saddle joint? Give me an example of a saddle joint in our body. I can think of two off the top of my head. Let's see if they jump out at you. Good. Karen Wilder wins the prize for the thumb. What's the other one? The hips are not a saddle joint. Good try. The thumb definitely is. There's one other place that we can find a saddle joint. Not the knees. So if I was to do my protraction, retraction, somebody's on it, Megan has it, right? It's actually it is the sternoclavicular joint that is a, give me that. That's a saddle joint. So a saddle joint is sort of cool because it can go in both directions, right? So the thumb is a good example of it. Collarbone too, I can go protraction, retraction, and elevation, depression. So these joints are doing this kind of motion or this kind of motion around it. So it's a nice, cool feature that gives us the ability to do opposition when we're moving fine motor with our hands, and it gives us incredible mobility of the shoulder girdle. So it's a very cool feature. The last one I have is ball and socket, and ball and socket is actually the easiest to reproduce. If you think of joint replacements, the easiest joint replacement is the hip, that ball and socket joint. It's a deep socket, it's well controlled, and it is maintained by the capsule inside that joint, right? The shoulder joint is also a ball and socket joint, but it is much looser, so it has a very small glenoid fossa. The fossa is the flat surface that the head articulates with, and an enormous head in relationship to the fossa. But if you think about the difference of purpose, we are an ambulatory animal. So we are bipedal. We need to have more stability in a deeper socket that fits our femur in the lower extremity. And then we are a open chain animal with our extremities, with all the things that we do with our arms. And so we need to have more freedom of movement in that joint than not. Now, there's a question that ties right into this is, what is a joint dislocation, right? And a lot of times you'll hear people use this word inappropriately, but a dislocation is a very severe injury, right? A dislocation means that my socket was disrupted so that that ball or that joint completely displaced outside of that socket. So that means that ligaments, capsules, blood vessels, nerves are going to be damaged with a true dislocation of major joints, right? And so that's why making sure that we have some way of repairing them is necessary. So, for example, I dislocated my shoulder when I was playing football in high school. And it kept dislocating once it dislocated the first time. It happened over and over and over again. And finally, I had to have a surgery at 16 to have it stabilized because it had now done damage to the labrum in the shoulder, as well as to some of the muscles and even some of the bone at a very young age. Hip dislocations are very severe. So somebody that has a dislocation of the hip can often have necrosis because they damage the vascular supply to the hip at a young age. So dislocation is different than subluxation. So a lot of times we use the word subluxation where we actually are talking about just a little bit of dynamic loss of alignment. A lot of times when you guys lay on your back, if you look and you'll notice your shoulders are still up off the ground. That's a little bit of a loss of that dynamic alignment. There's a loss of congruency or congruence in that joint. And that's what we want to make sure that we try to help our clients have greater congruency. And we definitely want to stay away from the idea of a dislocation. Dislocation will also disrupt other things as well, right? So you think of a fracture of a bone, you're going to disrupt the periosteum, the bone's going to start healing right away. In a dislocation, you're going to basically deform the connective tissue around that joint. So you're deforming the ligaments, you're deforming the capsule, and now you've lost the integrity of that congruency. And that's why you would see significant wear and tear in that joint over time because the ligaments can't do their job. And that's why surgeons are often quick to go in and want to do a tightening surgery to try to keep it congruent. Yeah. I have another comment from, looks like Julene Arden Rose. It says, would you expect a low back aggravation from a golfer's backswing with inability to adequately move the scapula on the thorax? And, one of the things I've said many times, sort of a funny way of looking at it, but I always say if you treated three things in our modern day society by increasing mobility in the thoracic, increasing mobility in hip, particularly extension, and increased mobility in dorsiflexion, we would take a lot of the stress off of things like our back, our shoulder joints, our neck joints, our knee joints. So in your question, Julene, is, would I expect the low back to be aggravated if they didn't have ample scapulothoracic movement? The answer is definitely yes, right? Matter of fact, I go the other direction. I make a bet with my golfers, and I said, I can add 20 yards to your drive just by increasing the thoracic and scapular movement, right? I can't promise where the ball goes, but I can promise that it's going to be at least 20 yards. And I've never lost that bet. I've made it with hundreds of golfers. I've never lost that bet. And in Pilates, it's such an easy thing for us because all we have to do is get them on the trapeze table and start working with the push-through bar and doing circumduction. And very quickly, they learn and can have restored that thoracic mobility. If you think about it, if they're already driving 200-300 yards and you add 2 or 3 more segments of motion and scapular mobility, you're going to easily add another 20 yards onto their drive or 20 meters onto their drive if you're not in the United States. All right, so that's some of our joints. I do want to know what you are thinking. If you like this kind of education that we could do periodically, I'd like to do it at least once a quarter, is to bring in a new physiology or movement science or motor science in conjunction with the in-between times that we're teaching movement. We're doing case studies. We're bringing in special guests. So your feedback is important to us. If there is part of movement science that is really you're struggling with and you want more of it, please let us know in the after notes or respond to Melissa or myself and let us know what other sciences of movement, because there's kinesiology, there's biomechanics, there's neuromuscular, there's motor control, there's motor learning. There's tons and tons of science that I think could definitely enhance our ability to be better practitioners. And the more we know, the better it is and easier it is for us to be able to identify movement dysfunctions and to be able to help people along. So I'm happy that we got through all of the material right within an hour. That makes me very excited. I'm glad to see some of the questions and the comments that came back. We will be back in tow next week. We have lots of things happening at Polestar. If you want to jump onto the Polestar website, we love it when you share with others that you are enjoying the Polestar Pilates Hour. So we look forward to hearing from you there. Did get a comment from Catherine Roberts. She says, I love it because it explains more about what happens to people in all the pathologies. Kinesiology would be amazing. And Catherine, the thing that I wanted to finish with today is that we are all performance kinesiologists, one way or another. Kinesiology is the study of movement. And I like to say to my physical therapist, you are a pathokinesiologist. Anything that impacts movement as a disease, psychological, that's our specialty. We know how to work with movement pathology. And on the other side of that spectrum is performance kinesiology. And this is where I feel like we as Pilates teachers have an incredible ability to be able to enhance people's performance by enhancing their kinesiology and their performance through these sciences, through the teachings, through the quality of movement, through the principles of movement. So again, I want to thank you all for joining me. Wishing you the very best of a weekend. Above all things, be kind, and I'll see you next week.